Good evening, everyone. Welcome again to Clinix Health Group. And being a Thursday evening, this is time where we share the knowledge amongst each other. And this is a time when some of you experts in the fields that you are in share knowledge, your expertise with your colleagues. It is a time that we value so much within Clinix Health Group. This is yet another one of the weekly Clinix Health Group sponsored webinars where we are able as Clinix to offer you free of charge presentations by some of your colleagues that are prepared to share, and we would like to encourage others to also do the same. It is such a pleasure that we have people for the 5th year running still willing to share their knowledge with others free of charge, and we really appreciate it. And we welcome others to do the same. And we also appreciate the sponsorship of these webinars by Clinix Health Group, which allows us to present them to you on a weekly basis and free of charge. Clinix Health Group is it's a company in the private healthcare sector that operates 8 hospitals. 5 of them acute care hospitals, 2 wellness hospitals, it is psychiatry hospitals, mental health care hospitals, and we also have a day hospital in the city center in Johannesburg. Thank you very much to Clinix for doing that. Just 1 or 2 house rules, because we always have new entrants as attendees in our emails. So if you've heard me say this, please bear with us. Your videos and your audios will be muted for the duration of the presentation by our speaker tonight. And but during that time, as the speaker goes through his presentation, you will be allowed. You may put your questions or comments in the chat box that is available, and the speaker will attend to them at the end. During the question and answer session that will follow the presentation, you will be able to unmute yourself. You can raise your electronic hand, unmute yourself, and you can will then be able to put your question or comments orally. We will also attend to your chat box inputs at the time during the Q&A time. Thank you very much for that, and we hope that all of you have managed to get this link by registering with it on the link that you provided yourself. But if you got it second-hand or third-hand, you may still register, but only for the duration of this, so that you can put in your HPCSA number. If you have not registered yourself, you got the link second-hand, then unfortunately, HPCSA won't be able to accredit your profile with CPD points. Those who receive CPD points will receive an email within 2 to 3 weeks from HPCSA, not from Clinix, so it will be from HPCSA. So look out for emails from HPCSA, which acknowledge crediting of your profile with the CPD points for this webinar. We thank you very much. I'll now introduce the speaker for today. Our speaker is a plastic and reconstructive surgeon, Dr. Sinoamadi. Dr. Vusani Sinoamadi works at both Chris Hani Bara Academic Hospital, but also at Dr. S.K. Matseke, Clinix Dr. S.K. Matseke Memorial Hospital. As a plastic surgeon, specialist plastic and reconstructive surgeon. He attained his MET, not MET, his MBSHB. Let's start with the initial degree at UCT. He then did his MET at Wits, Charlotte Maseke Christianibara Wits. That's where he got his MET. But he's also registered with the Colleges of Medicine of South Africa with a fellow of surgeons, of plastic surgeons, South Africa as well. He's got extensive experience in reconstructive and microsurgical procedures. Dr. Sinoamadi has a special interest in free flap reconstruction, in breast reconstruction, in burns and burns care, and also hand surgery as well. His earlier career has included positions as, of course, as I said, a registrar in Charlotte Maseke, but also as acting consultant for some time, as well as earlier surgical and burns unit experience at Polokwane Mankweng Hospital Complex before he decided to take his step further and become a registrar at Charlotte Maseke Vets. In addition to his practice, his clinical practice, that is, Dr. Sinoamadi is actively involved in teaching and mentoring registrars and medical officers, and he enjoys specifically teaching, and that is the reason why he's with us this evening and sharing his knowledge. He has contributed to research in reconstructive surgery and trauma-related injuries, and is recognized for his solution-oriented approach at all times, his technical precision, and he's got a strong interest in design, in fine art as well, and in surgical anesthetics as well. Dr. Sinoamadi, I think over to you. I'm going to mute myself whilst you continue, and Torakele will assist in the background with your slides. Over to you, Dr. Sinoamadi. If I've missed anything in introducing you, you may please add before you start your presentation. Thank you, Doc.
Okay, thank you so very much, Lucy, for the very generous and thorough introduction. Just one or two things to add. I am from Venda, Thohoyandou, that is home. And Johannesburg was where I did my schooling, and then to Cape Town for undergrad, and then back to Johannesburg Wits for postgrad. And it's been a journey, multiple provinces under the tenure and leadership of multiple individuals who have paved the way as role models, as guardians and advisors, and even examiners. So it is by many, many, many people and their efforts that I'm here today with you all. I see the participants are over 360. So I am humbled and I'm very thankful for people who have taken their time to come and listen to this talk, this webinar. And I hope there will be a reminder here and there, or maybe some new information and referral chains that we will establish today for the better care of our patients. So good evening, one and all. Can I start the presentation? Is that fine? Okay, so next slide. Okay, so this slide is just an algorithmic approach to thermal injuries. What I like about it is that it starts with classification of thermal injury based on depth, which would be superficial partial thickness, deep partial thickness, full thickness, and full thickness with involvement of underlying tissues. That correlates with first degree, second degree, A and B, third degree, and fourth degree. The fourth degree often being seen with electrical burns or high voltage injury. This classification is important for two reasons that come to the fore. One is that it informs your management thereafter, but also, and there's a prognostication that can happen there, but also for the fact that referral chains and centers can also appropriately refer based on the depth of thermal injury and therefore severity. So just a reminder there, first degree burns appear as red and dry with no blisters, positive capillary refill, supple skin, and are painful. And the healing that occurs within days, so 5 to 10 days. Superficial partial thickness being the 2A are pink or red and shiny, moist, blistering, positive capillary refill, supple and very painful, and healing would be within 1 to 2 weeks, so under 14 days. The deep dermal partial thickness burns are mottled pink or red with white spots, ruptured blisters, capillary refill present but delayed or absent in certain parts, supple to stiff skin with moderate pain to absent pain. And the healing will be from the islands of epithelium and the border of the wounds taking over 2 weeks. And then full thickness or third degree is our deep burns, and these are appearing white, yellow, brown, black, or red with a dull surface, no blistering. Capillary refill is not present, leathery, and pain is absent. This is referred to as an eschar, and there will be no spontaneous healing without intervention. And the fourth degree, you find comparable with aspects of third degree, but after debridement, you will have exposed subcutaneous muscle, bony tissue, so deep tissues. And again, there will be no spontaneous healing. The treatment following this would, for the first and second degree, would be conservative by nature, wound care, antibiotics, early active motion, etc. And this is wound management. We are taking care to remember that ATLS principles would be adhered to, and fluid management is the cornerstone of burn care. That goes without saying. And then for the smaller 2A, 2B wounds, again, conservative treatment possibly, lots of observation with excision and grafting if the burn wounds may be leaning towards deep partial thickness or full thickness. And then with larger wounds, you will consider tangential excision and skin grafting. This is a concept I'll speak on later. And then with fourth degree burns, it may be necessary if there is severe mummification of digits or extremities, amputation may be considered if necessary. Radical debridement and flap coverage is important. And that's often where the plastic surgeon is called upon by general surgeons, trauma surgeons, wound care sisters, orthopedic surgeons, neurosurgeons, depending on where the site of these burns may be. Next slide. It's important to quantify the problem, and there are modalities to measure the extent of total body surface area. A quick one for very small areas is the Palmer rule, which says that the patient's palm, not the surgeon or the primary doctor, the patient's hand correlates to 1% total body surface area. So you could map out patchy areas with that rule. The trauma texts speak of the rule of nines. It's still in the textbooks and the emergency medicine sources. The plastic surgery fraternity prefers the London Browder chart because it is more accurate in mapping out the total body surface area, which has an effect on calculating fluid resuscitation and intervention. So that is what is displayed on the screen here. Next slide. The burn depth that we spoke about is just represented here pictorially, where two images are showing all three depths of burn, where you have superficial as the erythematous area, mixed partial thickness as the red to white area, deep being the white, and the full thickness being the HR in the center. It's just important to remember that the burn wound is a dynamic living environment that will alter depending on both intrinsic factors, such as the release of inflammatory mediators and bacterial proliferation, i.e. infection, and extrinsic factors such as dehydration, systemic hypotension, and cooling. And this must always be kept at the fore of one's mind. Next. The slide is speaking on the zones of the burn wound. At the center, we have the zone of coagulation. This occurs at the point of maximal damage because of contact, usually with the thermal insult. And in this zone, there is irreversible tissue loss due to coagulation of the constituent proteins. Adjacent to that, or circling that in a halo sort of picture, would be the zone of stasis. And this surrounds the zone of coagulation, characterized by reduced tissue perfusion. The tissue here has a zone of potential salvage. So essentially, this tissue could go either way. It can become the zone of coagulation or become the zone of hyperemia, to be spoken about in 2 minutes' time. The main aim of burn resuscitation is to increase tissue perfusion here and to prevent any damage becoming irreversible. Additional insults such as prolonged hypotension, infection, edema, can convert this zone into a zone of complete tissue loss, i.e. zone of coagulation. And on the outskirts, we then are speaking about the zone of hyperemia, this being the outermost layer where tissue perfusion is actually increased. The tissue here will variably recover unless there is severe sepsis or prolonged hyperperfusion, converting it to a zone of stasis and then zone of coagulation. Next. So I would be remiss to speak about burns and the role of the plastic surgeon and not speak about the plastic surgeon's dearest friend and trusted co-pilot, negative pressure wound therapy, or VAC dressing. Negative pressure wound therapy may help the wound heal more quickly by draining excess fluid from the wound, keeping your wound moist and warm, helping draw together the wound edges and increase blood flow to your wound and decrease inflammation. The components essentially are the foam or gauze dressing, which is medical grade sterile foam, often polyurethane in composition, that is cut to fit exactly into the wound bed. Underlying this is usually a zone which may be created by Gelonet or Adaptic as a non-adherent layer. There is then adhesive drape or an occlusive layer that covers, which is a clear, semi-permeable, sticky film that is placed over the foam and onto the intact skin. There's also a sensor track pad and tubing. Small holes are cut into the adhesive foam, and a specialized pad connects tubing directly from the dressing to the vacuum pump machine. And finally, the vacuum pump is a portable, battery-operated or electric device that applies continuous or intermittent suction, drawing the excess fluid out of the wound. And this vac dressing converts an open wound into a closed wound, which is the plastic surgeon's best friend. Common applications would be, as this talk would allude, first and second degree burns or third degree burns post-debridement, severe bed sores or decubitus ulcers, diabetic foot, traumatic injury or severe crush wounds, surgical incisions that are at high risk of infection or dehiscence, and sometimes we use it as a dressing for our skin grafts or in conjunction to flap reconstruction. Next. I have to speak about Sir Harold Deft Gillies, um, who is considered by many to be one of the forefathers of plastic surgery. So he performed the first successful autograft in World War I to a Mr. Walter Yeo, a sailor injured in the Battle of Jutland. And this is assumed to be the first person to receive plastic surgery in 1917. How Sir Gillies was exposed to this was a post-war France, where he witnessed the rise in horrific facial burns from war. And the reason he's considered the father of modern plastic surgery, arguably, is for techniques that have helped repair facial injuries from war, as discussed. He's also was, between the First and Second World War, involved in gender-affirming surgery, but that's a topic for another evening. He was initially trained as an otolaryngologist and subsequently developed reconstructive techniques that combined with other colleagues, resulting in the advent of plastic surgery. Just not only does he teach the principles which I will go into in depth here, which are tenets for plastic surgeons, but also there's a lesson to more than just plastic surgeons and all of us about fiscal responsibility with what you earn. Because despite earning an astonishing £30,000 sterling per year between the First and Second World War, which is an incredible amount of money at the time, when he passed, he left an estate of only £21,000. So he earned well, but he clearly lived well as well. So just based on the principles, they are, thou shalt make a plan, thou shalt have a style, honor that which is normal, and return it to the normal position. Thou shalt not throw away a living thing. Thou shalt not bear false witness against thy defect. Thou shalt treat thy primary defect before worrying about the secondary defect to be created. And thou shalt provide thyself a lifeboat. Thou shalt not do today what thou canst put off until tomorrow. Thou shalt not have a routine. Thou shalt not covet thy neighbor's plastic surgery unit, handmaidens or theater scrub sisters, forehead flaps, etc., etc. So these are tenets that we live by. But essentially, it's about observation being the basis of surgical diagnosis and diagnosing before you treat, making a plan and having a pattern for this plan, making a record and having a lifeboat is having salvage options available to you and not burning bridges in case you need them. So planning ahead. Having thou shalt have a style speaks not just about having a good style, but having a predictable signature to the way you do things that is reproducible and identifiable by yourself and by others. Replacing which is normal in the normal position and retaining it there is fairly self-explanatory. Treat the primary defect first is talking about focusing on the problem in front of you instead of being concerned about problems down the line. And then losses must be replaced in kind. Do something positive. Never throw any living thing away. In plastic surgery, we say tissue and skin are gold. And never let routine methods become your master. Always think about the problem in front of you in a dynamic way, using up-to-date methods in your fraternity, and never just going into the brainless routine of a step-by-step without thinking. And then consult other specialists. Speed in surgery consists not in doing the same thing twice. When you consider operative time, also factor in any subsequent operations you need to do because you are trying to be fast. And aftercare is as important as planning, and never do today in a hurry what you could honorably put off tomorrow through rest, planning, and consultation of colleagues. Next slide, please. Next. We need to speak further about, if we can go back to the tenets of reconstruction, the previous slide. In plastic surgery, we speak about a concept called the reconstructive ladder, where the first rung of the ladder will be healing by secondary intention, which is essentially doing very little but wound care. And then primary intention is closing a wound primarily with the aid of sutures. There is an expression by one of the professors at Wits University where he says, when you are in the weeds, there you are alone and it is just you and your sutures. And then the second rung after that is, the third rung after that is a closure by skin graft. And then above that is bioengineered tissue, which we'll speak about a little bit later. A rung above that is tissue expansion, where you get more of the adjacent tissues that can be advanced to provide wound closure. Above that is local flaps, and then above that is regional flaps. And further up the reconstructive ladder would be free tissue transfer, which is a very useful and sometimes stressful modality. And then the highest would be tissue transplantation. There is a concept called the reconstructive elevator, where the first floor is direct closure, the second floor is skin graft, third is local flap, fourth is distant flap, fifth is tissue expansion, and the very top, the penthouse floor, would be microvascular surgery. The concept of the reconstructive elevator exists because sometimes you can go from the ground floor all the way to the penthouse without needing to climb all the rungs of a ladder if and when it's needed. What I thought was useful is also the concept of the reconstructive triangle, which looks at one corner being flaps, another corner being microsurgery and the applications thereof, and tissue expansion. And these three may work together to provide adequate cover of defects. A Bauhausian architect by the name of Mies van der Rohe is the one who is credited for coming up with the expression form follows function. And that is also apt in the human body. Things look the way they look because they work a certain way. And that's always a tenet we think about with regards to reconstructive and approach. But between form and function, we now add safety, and that's another triangle within the triangle. Next slide. Burn management is always a multidisciplinary team effort. There is no one member of the team who is a hero above the others, and they all work in conjunction with each other to provide the highest level of care for our patients. There is, the team consists of the team leader, and under him would be the burn team member, the acute burn surgeon, which is often the trauma surgeon or the general surgeon, who provides the acute or initial surgical management of burn wounds. There is also a critical care physician who provides medical management of burn shock, multi-system failure, and organ dysfunction, crucial member of the team. There is also the reconstructive surgeon, often a plastic surgeon in this case. This individual manages, or this member of the team manages, the aesthetic and functional deformities which are resulting from severe burn insults. There is also the specialty trained burn nurse, who is vital to the team, providing comprehensive daily burn wound management and assessment and dressing care. Another crucial member is the physiotherapist and occupational therapists, and they offer preventative roles through preventing functional disability, limiting contractures, and providing mobility protocols for our patients and fabricating thermoplastic splints. The clinical nutrition assesses for adequate caloric supplementation. The social workers, clinical psychologists, and psychiatrists manage the psychosocial factors that oppress our patients, preventing post-traumatic disorder, shock disorder, and the clinical pharmacists who manage drug dosing interactions and advise us on up-to-date pharmacological management. I think the slide is crucial, and I'm thanking every member of the audience who has at some point or currently is a member of the multidisciplinary team for burn care. Next slide. With regards to full thickness burns, it's just important to mention circumferential full thickness burns, which may result in compartment syndrome in the limbs and may interfere with respiratory function. For these, we do incisions in a fasciotomy pattern, and that is what is projected in this diagram as a reminder. But also to remember that there is a breastplate design to the release of the anterior chest wall in circumferential burns. This will allow for better respiration. So it's lateral to the pec and just at the clavicular line and just sort of along the lower ribs. And that would allow for a chest expansion. So that's the one area where you need 4 incisions as opposed to just the usual that we have. Next slide. I need to speak on tangential excision if it's a talk on burns. And in this concept, dead or damaged tissue is removed via shaving of thin sequential layers parallel to the skin surface until healthy vascularized tissue is reached to support graft take. Tangential excision is from the Latin word tangens, which means to touch. It's based on the pioneering work of Zora Zanzekovich in the 1960s, who introduced the concept of tangential excision to burn wound care, so more than 60 years ago. And essentially, conceptually, it's early excision of non-viable burn tissue followed by eventual wound cover. This revolutionized burn care because it leads to overall decrease in infection, decrease in overall blood loss, not necessarily in the setting of the tangential excision, but overall in theater visits, and reduction in the length of hospital stay, and significant decrease in mortality and better graft take. It's important to take note with tangential excision that it must be performed with careful attention to blood loss, which could be increased in the theater visit compared to total, patient body temperature, and viable tissue in order to be successful. On the slide is a picture of tangential excision of the dorsum of the hand using a Humby knife. This device has, in most centers, become relegated to museum status because it requires a fair degree of skill to use. I remember when I was a medical officer in the province of my birth, Limpopo, a professor would use a 20 blade and slide it between the roller and the blade of the Humby knife to determine the adequate thickness. And it requires very slick back and forth movement to remove carpaccio shavings of tissue. But if you're not careful, you can cause quite a bit of damage by going quite deep, and then you're converting your wound to 3rd or 4th degree. The picture also shows litless scissors, diathermy or electrocautery, and a device called Misonics, which I'll speak about in a second, which is ultrasound and hydro dissection. So with regards to tangential excision, surgical decisions need to be made early, 24 to 48 hours of injury, by the primary surgeon to consider whether tangential excision is necessary. Burns that are superficial and appear to be capable of healing within the 14 weeks we spoke about in the second slide should be managed with standardized, conservative wound care principles. But burns that are clearly full thickness or appear to have no possibility of healing within the 2-week mark should be treated by excision and skin graft at the earliest possible convenience. Next slide, please. This slide is just to contrast hydrosurgery with ultrasonographic surgery. On the one side, we have Versajet, which utilizes a high velocity stream of sterile saline to create a localized volume and dissection. This simultaneously cuts, lifts, and suctions away necrotic tissue, infected tissue, or damaged tissue. And on the other side, we have Misonix, which is an ultrasonic surgical aspirator system, which is intended for ultrasonographic fragmentation, emulsification, and aspiration of tissues. It is a wonderful device. In the instances where the burns are more superficial, chemical debridement agents may be considered. These are broadly classified as chemical debriding, such as Milton solution or hydrogen peroxide, and enzymatic debriding agents like Roxol and Veridase. Next slide. Just in the back of our minds, if we can keep a burn scar index, and the original that we have is the Vancouver scar scale, which has been modified many times since its development in the 1990s. But it has 4 characteristics of the scar to be assessed. These are vascularity of the scar, pigmentation of the scar, pliability of the scar, and height of the scar. And these are used to come together from a range of 0 to 13 points, where the scar is scored from 0, apologies, which is normal skin, to 13, which is the worst scar imaginable. And the lower the scar score, the better the surgical outcomes. Next. So the slide is included as a decision-making algorithm for skin contractures. The Fraternity of Plastic Surgery relies heavily on algorithms for teaching purposes and communication purposes in terms of approaching problems, wounds, and defects in a systematic and reproducible way. So the first one stratifies the skin into either a wide scar or a linear scar. Wide scar correlating more with a sheet. So wide scar is the joint area involved. If yes, you then must excise. And then the first attempt to correct, yes, with a skin graft, or not possible, then with flap cover. And then extensive contractures will require all limbs of the algorithm. And then from there, if the joint area is not involved, you consider excision and flap coverage or Z-plasty. If it's a linear scar or a band and the joint area is involved, you consider excision. First attempt at correction, yes. You consider Z-plasty, V2Y plasties, butterfly plasties, and early rehabilitative programs after healing or surgical intervention. If first attempt to correction is a no, then flap coverage or Z-plasty. And if joint areas were not involved, you go back to excision and flap coverage or Z-plasty. And then the other picture is considering joints, tendons, and under joints is there stiffness, and you consider arthrodees. Ankylosis, then you consider arthrodees, DIP and PIP joints, or arthroplasties, MP joints in the wrist. And then from there, skin defect after arthrodesis, you consider flap coverage, which is where the plastic surgeon may come in contact with the cases. And then with regards to tendons, consider tenolysis, two-stage tendon reconstruction, tenodesis, joint fusion. Again, rehabilitation programs after healing and surgical intervention. Next slide. So this is to cover something that is seen quite a bit, both in state and in the private sector, which is anterior neck contractures, which prevent extension of the leg and can be quite debilitating and limit activities of normal daily function. So again, they are stratification systems, and the one that's projected here is classifying anterior neck contractures into primary, secondary, and tertiary. Primary be involving mild anterior contracture, where the patient is able to flex the neck and bring the neck and jaw to the anatomical position while erect. And there is A and B, which is narrow broad. Two being moderate anterior contracture, attempts to extend away from the anatomical position results in a significant pull at the lower lip, again, narrow or broad. And three would be severe anterior contracture, where the patient's neck is contracted in a fixed position and the chin is occasionally restrained down to the anterior neck, and the patient is unable to reach anatomical position of the neck and jaw, where normal is between 90 and 120 degrees. Next. Again, we need to speak about the severe burn sequelae of post-burn axillary contractures, which are also quite common. And here are two representations. I believe they're both from the internet, or one is from VidCircuit and one is from the internet, just to show the degree of debility happen with anterior axillary wall contractures, which can also be addressed by the plastic surgeon. Next. An approach can be Z-plasties with two large flaps if it is a contracture band and not a sheet, where there is normal tissue adjacent to the band, and it can be transposed into that area, allowing lengthening and reconstruction of that axillary dome or anterior axillary wall. Next. This is one of my favorite pictorial representations by an artist and plastic surgeon, I forget who, but essentially this is entitled The Tree of Flaps, and it's just a reminder about the arterial network that underpins flap reconstruction and just the myriad of options that are available to the plastic surgeons, from the lateral arm flap to the radial forearm flap and other options which are available. And it's just a reminder about the interplay of anatomy, planning, and the possibilities are essentially endless. The tree of flaps gives us pedicle flaps, but also in some instances, a donor for free tissue transfer. And sometimes for flap cover, a burn scar may itself be used as part of the flap, as perforators to the deep fascia are usually protected in more superficial burns, but obviously not in deeper burns. And a variety of free flaps have been used, including the latissimus dorsi, the lateral arm, the scapula, parascapular, gracilis, and the anterolateral thigh flap. And these are in the armamentarium of the plastic surgeon for reconstruction of defects from burns and other modalities. Just free tissue transfer can be difficult because it requires a fair degree of surgical prowess, and bridge the different defect area, different thickness, and creativity is required part of the plastic surgeon, reconstructive surgeon, to provide aesthetically pleasing outcomes along with functionally successful reconstructions. Next slide. Next slide, please. Well, okay, so from this tree of flaps or tree of life, if you want to be philosophical, is the parascapular flap, a flap that I have some experience with, often for reconstruction of axillary defects from hidradenitis suppurativa post wide local excision, but can also be applied to axillary dome defects from severe burns. These flaps are actually based on circumflex scapular artery from the subscapular artery. And there is a myriad of applications of this flap, from shoulder reconstructive, axillary dome reconstruction, some back reconstruction as well. The learning curve is not too bad, and it's just a useful, nifty flap to keep in one's back pocket for reconstruction. Next slide. Next slide, please. Thank you. These are pictures from a case in state, borrowed with the permission of the patient and with the permission of the primary surgeon, who happens to be the presenter today, where a parascapular flap was used or harvested to close a defect in the axilla from early stage 3 hidradenitis post wide local excision. It's useful, and in the last slide, you can after here, there is improved range of motion of that shoulder, and applications are endless, including for burn care reconstruction. This has been added just as a pictorial example of what is possible. Next. So this slide is speaking about an approach to burn reconstruction in a diagrammatic representation of aim, which would be functional improvement, cosmetic, and comfort to improve the patient's life. A former mentor of mine and a professor in Limpopo, Mzizewa, would often say, our duty as plastic surgeons is to make ugly and to make the ugly acceptable. So often with reconstructive surgery, the aims are different, but that is something we keep in mind. The 5 P's of reconstruction are: always consider the problem, prioritize, consider your possibilities or options without burning bridges, perceptions, and have a solid plan. And in terms of strategy, there will always be assessment, prevention, early excision and grafting we spoke about, positioning and splinting, which our allied colleagues help us with, early scar management, and reconstruction. But you have to often delay definitive reconstruction to a stage where there's scar maturity, or at least the wound area has been optimized for your recon. Next slide, please. Often a temporizing initiative be skin substitute, and this is just to project the different options which exist. They classify them via cellularity, you know, cellular layers. It can be single layer or bi-layer, so epidermis, dermis, bone materials is another classification. Permanent, it could be biodegradable or non-biodegradable. And often plastic surgeons and reconstructive
Tolakele, is Dr. Sinoamadi still audible?
I think we've lost him, Doc.
We apologize for this. I'll give Dr. Sinoamadi a call quickly.
Yes, we've lost Dr. Sinoamadi. He's offline. He left the room, so.
Yeah, okay, I'm giving him a call. We apologize for this. Please, let's wait. I'm giving him a call, Tolakele.
Okay, thank you, Doc.
Tolakele, just check for Dr. Sinoamadi in the waiting room, please. Dr. Vusani Sinoamadi. And he says he's in the waiting room. Oh, there he is. Thank you very much, Doc. I see you're back.
Thank you very much. My sincerest apologies. It may have been a issue on the forum that logged me out.
Yeah.
I have many more slides
maybe
to go.
you
Brief. I can have
you
5 more minutes.
That's fine. You can keep if your bandwidth is narrow, you can keep your camera off. It is fine as long as we can hear you. It'll maybe assist to some extent. Okay, and then all right. We can see you clearly.
Can you hear me?
We can hear you, but
thank you so much.
If it happens again, Doc, you can just put your camera off then, but then you continue speaking.
Okay.
That's right.
Okay, thank you. Apologies.
No problem. No problem.
There's not very many slides left to go. I just wanted to speak a little bit about dermoregenerative matrices that we often use as part of our reconstructive armamentarium, such as Integra. We can go to the next slide. The majority of the slides of Sculpt are actually borrowed from a senior colleague and mentor of mine he had done, where a very large scalp defect was covered with a dermoregenerative template and vac, and eventually granulate skin grafted. So those are borrowed with thanks from him. And in the corner is an internet picture of a dermoregenerative template to the axilla. Eventually was grafted as well. So this is often an adjunct we use. Next slide, please. Thank you very much. Just in closing, just some pearls to consider is that key points for successful surgical treatment of a full thickness burn involve removal of all abnormal tissue, skin approved by the patient in a cosmetically inconspicuous area like the thigh, which would be covered by skirts or trousers, limiting blood loss with injectable and topical adrenaline, dressings with or without splinting as needed to prevent shear, and early motion to maintain function. Next slide. In closing, there are 6 R's pertaining to this topic, which are rescue, resuscitate, refer, reconstruct, and rehabilitate. And I would add a 7th, which is remember your reconstructive team. And then the next slide, please. This slide is included. This is a case that was done recently at SK Matseke Memorial Clinix group, where a patient who had a long-standing wound, very proximal lower third, from a tibial reconstruction that broke down, unfortunately, with exposed hardware. My involvement was to cover the defect. And what was done was a medial gastrocnemius flap. And in the second picture, you can see the incision to access the flap. The flap after it had been cut at the insertion of Achilles. And then the third picture is the flap that has then been moved into the defect. See that there's access or slack. So no tension there at all. And eventually, our last picture is after skin graft has healed in the wound care environment. Of note, this was a diabetic patient who was also morbidly obese, but the defect was covered. Next slide. Next, please.
It just slow. It changes slower on your side, Doc. But I
Okay.
think
Not a problem. Thank you very much. With the previous slide, a lot of you may be asking, so what does that case have to do with burns? Or is Dr. Sinoamadi just shamelessly self-promoting? But sometimes severe burns to the lower limb may result in defects with exposed bone, where there is no other option but flap cover. And some options may be tibialis anterior or gastrocnemius or soleus or a combination thereof and skin graft. So that's how it ties in. Next slide, please. And just for us to think and possibly collaborate with ideas in the future, a pending case in the state sector is actually a child who sustained very severe and disfiguring sequelae of a thermal injury. The child was left alone at the age of 2 in a room where light was provided with a candle. The candle tipped over and resulted in a fire that burned the child. The child is presenting at the age of 5, and you can see there is disfigurement of the lower third of the face with severe scarring and a defect to there is indeed retraction And the scars, maybe once released, would allow for some advance of that lip. But there is a reconstructive algorithm that plastic surgery, usually that involves local regional options from the cheek, and both are burnt. The upper lip on the side of the defect on the lip is also burnt, so lip sharing options may be tricky, and the submental area is also burnt. So this limits the options available to the child. The child does not have oral continence and is drooling. The child also has an anterior neck contracture, bands more than sheets. They're not very severe. As you can see, extension is possible, but can be released. And then also there is contracture of the anterior axillary wall, which we discussed before. So the approach with this would be the reconstructive ladder. And I'm sharing these pictures to just show the extent of disfigurement. This child would be starting school next year, and you can just imagine the bullying and the teasing and the isolation from burns, the secrete, the severe, and also the functional limitations of drooling all the time and not being able to abduct that shoulder. And something definitely done using principles, concepts discussed earlier on in this presentation. And then the last slide, please. Next. The slides are thank you to the organizers, to the Clinix group, and to all participants who are just shy of 500. I'm deeply, deeply thankful and humbled yet again by all of you taking your time to listen in to this. Apologies for technical issues that have required somebody else to assist me with moving on to next slides, and also at some point where I was kicked off in the middle because of time. But essentially, this last picture is a bronze sculpture by the sculptor Tim Shaw. It's entitled Man on Fire and is actually a tribute to the devastation caused by war and thermal injury. It's now permanently installed outside the Imperial War Museum in Greater Manchester, and is just a reminder of how much damage can be in the world, but yet how much help and hope is possible because of some of the people on this forum. Thank you very much. These are a list of some of my references. Some of them are a little out of date. There are newer versions of these books available, but these are the ones I had. And thank you all for your time. I hand back to the coordinator, and I believe next may be a Q&A session, which I'm looking forward to. Thank you very much to one and all.
Oh, thank you very much, Dr. Sinoamadi, for a wonderful lecture. I think we all gained so much from it. I'm impressed with the detailed slides that you had prepared. I think it just shows the effort you took in preparing this talk for us this evening. I'm truly grateful. And I'm not the only one, because you can see the applauses and the thumbs up on the screen, but from everyone. I think every one of the 492 at one stage attendance when it was at its top, I think are quite impressed, and I think with your lecture. I think some of the things you said, are new to us. I mean, how many people knew that about Sir Harold Gillis, who he's talking about? You spoke about who you say is the father of plastic and reconstructive surgery. I think that's amazing, and the fact that he was originally an ear, nose, and throat surgeon, you said. I think it's amazing that he ended the way he was, and his principles as well that he put for all plastic surgeons. I hope some of your registrars had logged in, and registrars all over the country, because they would have learned a lot from this lecture. You spoke about the crucial aspect of multidisciplinary teams in management of burns, which is very important, something that we should never forget. Whether we're in single practice or in group practices or in hospitals, we should always ensure that we work with the nurses, the wound nurses, and all other team members who are from other clinical disciplines who may be needed for the best to get the best benefit for the patient. Dr. Sinoamadi, I'm going to go through to the chat box, but if any of the members of the audience would like to put their questions or their comments orally, you may just lift your electronic hand. We will recognize it. I've got a team assisting me with me in the room, Tolakele and Neo and Sister Nesisa. And then we'll unmute yourself and we can put your question orally. Let's take the first one that I can see from Professor Duplessis. Professor Duplessis is a regular attendee, is a cardiothoracic surgeon, Dr. Sinoamadi. And Professor Duplessis is asking, how does the ultrasonic cleaning device differentiate between necrosis and live tissue? He's asking because ultrasonic waves are also used in coagulation of tissue. Any comments from yourself, Dr. Sinoamadi?
Thank you, Professor Duplessis. This is an excellent question and one I've had myself. The advantage with this Misonix ultra sonographic hydrodissection is actually the exact mechanism of action or methods. I still need to expand upon for my own, but it's such a device that has between very gentle, which is 1, all the way up to which is fairly aggressive. And what 1 does is below 1 can essentially just hover the Misonix over the wound. And what that does is it washes the wound with whatever solution is being pushed through. 1 is incredibly gentle and can even be used just to remove biofilm on the surface without causing deeper damage. And then you adjust the dial, a digital dial, all the way up to 10, which is more aggressive for deeper areas. We often use it at a setting between 7 and 9 for in the burn unit sort of setting. But you can dial it all the way down to 1, and it's very gentle. 1 in itself would not cause damage and is more like an exfoliating feature. How ultrasound specifically works, I will have to go and check email, Prof. But what is reassuring is that there's just a very wide range from 1 to 10. And then between knowledge of depth in a particular area, the device and your objectives or goals, it's often more useful than harmful. I'm actually yet to see a case where we have inadvertently gone deeper than intended. It happened a bit more with the Versajet, and definitely happens with blades and scissors. So it's a device I endorse, and I'll contact a rep and get my and email further information. Thank you.
Thank you very much, Dr. Sinoamadi. I see there's a question from Dr. Matthews Banda. Well, there's a hand. Dr. Banda, you can unmute yourself and put your question, please. You can go ahead, Dr. You unmuted and then muted again. Yeah, okay, you can go ahead now.
Thank you very much, Dr. Sinoamadi, for an excellent presentation. My question, I'm also from the Limpopo province. In terms of burns, do you find that they affect more children, or is it adults that are mostly affected by burns, especially in a rural province like the Limpopo province? Thank you very much.
Thank you very much Thank you very much for your question, Dr. Banda, and thank you very much for attending this webinar as well. Burns can be quite frequent in areas, thermal burns can be quite frequent in areas that have lower socioeconomic populace, because fires are used for heat, for light, and for the convivial element of congregating around and cooking as well. So between paraffin lanterns, between open flames and candles, there are quite a lot of burns in provinces or areas where patients have fewer socioeconomic options for heat and light. So you see them quite a bit in Limpopo. The distribution between children and adults was quite surprising for me. I think for the majority it is adults. That's also reflected in the burn unit bed numbers for peds versus adults, and also ICU numbers for peds versus adults. But what can be devastating with children is that their tolerance for TB, total body surface area insult, and fluid shifts and insult with burns and with burn resuscitation is much more devastating than adults. So in pure numbers, I think burns happen more in adults, but the devastation, the sequelae, and morbidity and mortality can be higher in children, because you can imagine the body surface area of a smaller patient from a thermal insult is larger in a smaller patient, and also their tolerance to the physiological insult is much worse than it is in adults. But this is an excellent question, and I hope in some part I've answered it, Dr. Banda. Thank you.
Thank you very much, Dr. Sinoamadi. Dr. Rose Tebogomotuba is asking whether you have ever had to deal with severe radiation skin burns. Radiation skin burns, Dr. Sinoamadi?
Thank you for the question. If I may ask for clarification, do we mean radiation injury from iatrogenic radiation, or are we talking about radiation injury in the workplace setting, which is not a common thing? Which one are we referring to before I go further?
Yeah, I'm not sure whether Dr. Mtuba is asking for the ones that are commoner from radiation therapy, rather than if you have a radiation burn like in an accident, but maybe let's address the ones from radiation S therapy, radiotherapy, because those are the common ones. So let's talk about those.
So experience with that specifically, no. The principles apply, and the one thing that comes to the fore about my fraternity or my discipline is that principles and concepts can then be applied to a myriad of clinical problems. And what that results is, with a little bit of creativity, problem solving can happen even though you haven't seen something before. You can apply principles and solve the problem. We see a lot of wound problems with post-radiation from a range from osteoradionecrosis to wound healing issues, etc. Burns specifically, I haven't dealt with, but I think I still have an approach to burn injury in general. And without saying I welcome the challenge, I think I am up to difficult and complex reconstructive problems to find solutions for. And in the advent of modern technology, where everyone is an expert between Google and journals, that and my professors who remain ever available to bounce ideas, to have a think tank and approach. It is my limited experience and their broad experience over decades. And between them, myself, journals, colleagues, and Google, I think almost all burns can be approached. I hope I went some way to answering the question.
Right, thank you very much. Dr. Itumeleng Mutong is asking, what is the management of burns in a person who is prone to keloids, prone to developing keloids?
Is an excellent question. The reason I'm a little flabbergasted with this question is because it is more common than I would like. Now, the problem is the principles of burn management would remain as discussed in this talk. But if the person is healing with hypertrophic scars or keloiding, it results in an added layer of complexity to the problems, because you may be able to cover the wounds, you may be able to reconstruct, but eventually you are left with the morbidity and the functional limitations and the disfigurement of keloid scarring. There are some non-surgical modalities which we do employ, certain dressings, and non-surgical modalities we do employ which can address keloids. But the truth of the matter is we would deal with acute burn care, then reconstruction, and in the reconstructive dressing phase, in a person we see keloid, we would have to employ those modalities. One of them being post-keloidectomy radiotherapy, which ties into the previous question. So this would then be quite a complex problem, but we do occasionally see it. I believe the slide I had of the patient with the anterior neck contracture had an element of hypertrophy and keloiding. So it is a fortunate common problem, but you would have to tackle it as a multimodal, multidisciplinary thing that has a lot of components that are moving at the same time. But again, principles still apply as discussed in this talk.
Thank you very much. We have a physiotherapist, Kabelo Mapike, who's asking, at what stage should we physiotherapists start mobilizing joints post skin graft to prevent contractures?
Thank you for that question. Perhaps that I was taught, and I think still applies to the grafts that I've done, both in state and in a forum such as private healthcare, we do the skin graft, and sometimes the vaxing or splinting may be done immediately, depending on if the skin graft is over a joint, wants to control immobilization in a very strict manner. Graft is then assessed at first exposure at 5 days and at second exposure at 7 days. And then from there, we allow for wound healing. And then MOBs would be discussed on a case-to-case basis, depending on the area involved. So we will always be in communication, in dialogue with the physiotherapist and the occupational therapist, depending on the type of graft that is being done. I spoke about split thickness in that timeline. Full thickness would be up to 10 days. So the type of graft, the area being grafted, let's say joint or non-joint involvement, and the requirements thereof. So it's a case-by-case thing, which is always a good thing. Again, the Gillies principle of not being under the governance of the god of routine, and always consider case as a standalone individual.
Thank you very much. There's a question from Dr. Makai, who says, we often focus on wound management and rehydration, right, which you really emphasized. But he says, what is the pain control management or protocols when it comes to pains when we have burns, Dr. Sinoamadi? Pain management.
This is also a very pertinent question. Research has shown that inadequate pain management also affects wound healing, a respiration limitation, etc. And this, just from a humanity point of view, pain management is a crucial cornerstone of burn care. And it's multimodal pain management, which often involves an opioid-based agent, an anti-inflammatory, basic analgesic, and a plan for breakthrough pain. Advance in things such as PCAs, patient-controlled analgesia, it has been quite useful, especially in the post-surgical arena or area, and also your follow-ups, your daily ward rounds, always balancing your pain management medically with the patient's level of pain, never over managing, which leads to dependency, and sometimes in the setting of opioid-based analgesia, things like respiratory depression, or under managing, which leads to pain not being adequately addressed. It's a constant balancing act that requires discussion and discourse between the patient, the doctor, the nursing sister. But essentially, in a nutshell, multimodal pain management would be my answer. Thank you.
Thank you very much, Dr. Sinoamadi. There's a question from Dr. Moraba. Dr. Moraba is asking, is in relation to hypergranulation in burns. And he says, is the management of hypergranulation only skin grafts, or is there a less invasive way to deal with smaller areas of hypergranulation?
Thank you very much for this question. If I understand the question, the skin graft is a resurfacing option along the reconstructive ladder or elevator. So certain wounds are amenable to closure with a skin graft. Sometimes a skin graft is a temporizing measure, but it is a modality to cover or resurface a wound. Hypergranulation can happen because of a delay in the time between a wound that is ready for grafting and when the graft actually happens, for a variety of reasons. But if you are eventually going to resurface a wound with a skin graft, that hypergranulation can be addressed and removed and grafted on top of it. So if the other side of the question could simply be certain wounds which are eventually going to close by secondary intention without suturing, without resurfacing with a graft, a flap, or free tissue transfer. But usually those would not be very large burns. So the word hypergranulation, I'm trying to reconcile with the talk of burns. And if you're going to need a skin graft, that means the skin graft is indicated and appropriate. And that would address the hypergranulation because you would remove it at the time of applying your skin graft. But if it is a wound that is expected to close by itself without a skin graft, they're usually smaller wounds and would eventually re-epithelialize from the edges. So I don't know if I'm tackling it further. Maybe the question could be rephrased to be more focused, but I hope I addressed it in the one of two approaches I gave to when you skin graft, why, and when you wouldn't do anything at all. Thank you.
Thank you, Doug. I think you've addressed it adequately. The next one is from Dr. Barbara N. Ribeiro. Hello, Babsi. Dr. Ribeiro says, Dr. Sinoamadi, you mentioned donor skin in passing, donor skin. Are the requirements as stringent as those of organ transplantation or organ donation?
No, this is actually, thank you very much for the question. It's an excellent question. Thank you, Barbara. There's a whole chapter in the holy book of plastic surgery, Grab and Smith, about organ transplantation, transplantation concepts in general, and that's the very top of the reconstructive ladder. But no, they're not. These are essentially autografts. Skin grafts are autografts from the patient. The body does not immunologically reject a skin graft from the patient. In certain instances, the graft donor is not from the patient. Usually in the setting where it's very extensive burns and you simply do not have enough donor from the patient. You can imagine a patient with a total body surface area of 90% may have a donor availability of 10%. And even with adjuncts such as meshing, which expands the graft, or meek, you still would not have enough donor from the patient. Then we look at other sources, and immunologically speaking, sorry, tongue twister, English is a second language, you would then have the similar issues to organ transplantation you're dealing with, which is essentially rejection. The rejection is also not straight away, so you do buy time where you have a biological dressing. But with the patient's own skin, no, rejection is not something you see unless there is an enemy such as infection or a technical error where maybe a novice surgeon puts the skin upside down or some such thing. But usually the skin is not rejected. And even within minutes, you can see the stages of skin graft take where it's being accepted. So that's not a thing we see. What we often face is issues of donor site availability if it's an extensive burn, or areas of donor which are then not hidden if it's extensive. The books speak about the gluteal area, the lower leg, and chest and abdomen if you are really pressed. But that can lead to hyperpigmentation in those areas, and they can be conspicuous and unsightly if there are areas which cannot be hidden under garments, such as tops and trousers. I hope I've addressed the question. Thank you.
Thank you very much, Dr. Sinoamadi. I think this may be the last question, or but the last but one. This is from Dr. Motlante. He says, ordinary people still think that plastic surgeons put plastic in heal to heal burns. You think you put plastic? I've never heard that one. But he is suggesting that maybe this discipline should be called reshaping and reconstructive surgery, because the word plastic means reshaping or remodeling of any malleable flesh. What do you think about the name plastic surgery?
That's actually a very interesting point, and I'm thankful for it. Um, my Greek is not so great, but I believe the plastic part of plastic surgery is from a root word plasticus, which means to mold. So before plastic existed as the synthetic material we know, which when heated is malleable and can be molded, the root word is from the word mold. So what my colleague is suggesting is actually the definition of the root word used in plastic. Yes, it's true. Sometimes some of my patients come and say, they told me I could come and get plastic put in, plastic surgery. And they don't mean an implant. That's just in their with the knowledge they have, that's what they believe they're here for. It can be misleading as a modern word. I don't think we're going to have much luck changing the name, but it does lead to a fun anecdote in the start of a consultation sometimes, which lends brevity and lightens the mood. But I'm thankful very much for that comment and question.
Thank you very much, Dr. Sinoamadi. Dr. Gertrude Mukalabai Akun says, what is the latest on porcine grafts? Porcine grafts.
So this ties into possible donors, which can be from yourself, from another human being, which I saw a great deal of in yes,
I
porcine
think
being
it's
pork.
porcine
Porcine
grafts.
meaning pork.
Porcine
Yes, I was leading there. If you could just extend me a few minutes to get there.
No
Um,
problem.
so the skin could also come from a human being other than the patient, which I saw a great deal of in Limpopo, where children were burnt with extensive TBSAs, and their mothers would also be donors for the skin. We know the skin won't take, but you have close to 2 to 3 weeks of a biological dressing, allowing the child's own donor areas to reepithelialize and can be reharvested from, and then skin from species other than humans, which is where porcine would come in. There has now been advents where a skin of a patient can be grown from a few cells in a lab and provide sheets of skin. It is relatively expensive, and I don't know if there are any labs in South Africa. So a sample is then sent overseas and then shipped back after a few weeks when skin has been grown. So there are multiple areas, but this porcine skin would fall under a species other than human. I do not have personal experience with it. We often use porcine tissue to grow cellular layers with our dermal regenerative templates. It wouldn't be skin necessarily, but it would be a component from aquatic animals, from pigs, from cows. But sheets of skin from pigs, porcine, is not something in 2026 we are using a great deal of. It is something worth knowing academically and may form components of advanced technology, of layers of options that can resurface or allow granulation in skin grafting. But it is something that is there. There may be advents in that tissue, not to resurface large total body surface area in humans, but components of can be used for all sorts of technologies, for dermal regenerative matrices. So it's an important question, but as a pure form of skin graft donor is seen less so. Again, it's one of the things that are maybe not the most up to date on, but I hoped I I gave a scenic route to that answer that is sufficient for the person asking it. Thank you.
Oh, thank you very much, Dr. Sinoamadi. I would like to, thank you a lot, for your eloquent presentation today. I think you made plastic surgery such a wonderful discipline for which I think many people in this room would choose to go to if they had a choice. It's the first time, by the way, that as far as I can remember, that we have a plastic surgeon, plastic and reconstructive surgeon presenting in our webinars in the 5 years I've been here. I can't remember. I've been trying hard to remember. We've had all kinds of clinical disciplines presentations, but I think you've broken the barrier now, and I think we're hopefully going to have a lot more, and maybe we'll have you back on another topic in plastic surgery, presenting after some months, a few months or a few weeks. I think it was a wonderful. I think I enjoyed it. We now know so much about plastic surgery as a discipline, much more than what we knew at the beginning of your talk. I'd like to thank you. I'd like to thank all the attendees who give of their time to, first of all, to improve their knowledge in the interest of patient care. You remember, all this is being done in the interest of for patients' benefits. They benefit from knowledge of us, the practitioners, and I think you sacrificing 1.5 hours of your time every Thursday is so wonderful. Next week we will be back again with a pediatrician next week with an amazing topic. We will tell you about it in a few days' time when we send out the webinar invite to everyone early in the week. Dr. Sinoamadi, I'll give you a call. Thank you very much to you. And I think Tolakele will also be in contact with you by email tomorrow as well. But thank you very much to everyone who participated tonight. I would like to say thank you to my team as well. In the background, you never see them, but they're always so active and making sure that we get these presentations into your room or your office, wherever you are. Tolakele, Sister Nesisa, Neo, thank you very much. And good evening to everyone.